Good evening, everyone. I'm Barbara Broom, Dean of Kent State University College of Nursing. I'd like to welcome you here this evening to our May 4th commemorative event. It's highlighting PTSD from May 4th through present day. Tonight, I hope you walk away with not only a historical understanding, but a modern-day perspective on the field of post-traumatic stress disorder, or PTSD. May 4th was a traumatic and devastating event locally and nationally, and trauma is a daily occurrence in the field of healthcare for practitioners and patients. Fortunately, PTSD research is growing, and how we address it personally and professionally is evolving as well. Tonight, our aim is to highlight the past and focus on the future of this critical field. Now, I would like to introduce tonight's moderator and our Associate Dean for Graduate Programs in the College of Nursing, Dr. Wendy Umberger. She is a two-time graduate from Kent State, earning her bachelor's degree in nursing in 1982 and master's degree in nursing in 1986. She practiced as a psychiatric mental health advanced practice nurse for over 30 years in a variety of clinical settings and has worked with patients diagnosed with PTSD and other stress disorders. Please join me in welcoming Dr. Wendy Umberger.
Good evening and welcome. Shell shock, combat exhaustion, traumatic neuroses, gross stress disorder, combat fatigue, rape trauma syndrome, post-Vietnam syndrome. It's gone by many names. However, symptoms that are associated with post-traumatic stress disorder, or PTSD, have been cataloged for thousands of years and existed as long as mankind has experienced trauma. In the collective mind, PTSD is often associated with the legacy of the Vietnam War. An estimated 700,000 Vietnam veterans, almost a quarter of all the soldiers that were sent to Vietnam from 1964 through 1973, required some sort of psychological help. Research related to post-Vietnam syndrome in the 1970s, along with trauma experienced by Holocaust and domestic abuse survivors, was a pioneering force in drawing attention to the effects of trauma. It also gave way to further understanding and an official description of PTSD. In 1980, PTSD was adopted into the Diagnostic and Statistical Manual of Mental Disorders, which was and continues today to be the definitive text for diagnosis of psychiatric disorders. Despite its legitimization as a diagnosis in 1980, not everyone back then thought PTSD was a real illness. Some claimed that symptoms of distress were a normal response to exposure to abuse or violence, whereas others were concerned that the diagnosis could be used to manipulate the system for self-gain, including financial benefit. Some even went so far to consider it a publicity stunt by feminist and veteran groups. Veterans with PTSD symptoms back then often faced rejection by their military peers and were even feared by society in general. Today, PTSD is recognized as a trauma and stress-related disorder resulting from direct or indirect exposure to actual or threatened death, serious injury, or sexual or emotional violence. It is characterized by persistent difficulties that negatively affect the person's social interactions, capacity to work, or other forms of functioning. Today, PTSD is thought to result from all types of trauma, from battlefield experiences to natural disasters, to rape and assault, to terrorist attacks and school shootings. And it is recognized as a human response to trauma versus human weakness, shortcoming, or secondary gain. Recent data from the National Center for PTSD at the United States Department of Veteran Affairs shows that about 4 out of every 100 men and 10 out of every 100 women in the United States will be diagnosed with PTSD in their lifetime. This evening, our panel discussion has several objectives. First, we want to provide state-of-the-science information about PTSD and treatment. Next, we want to analyze advances in the field of PTSD. And lastly, we want to identify biopsychosocial risk factors for PTSD. I, as the moderator, have developed a series of questions that will help elicit the knowledge and experience from our panel of experts so that we can try to meet these objectives. This discussion will last about 25 to 30 minutes, and then I will open questions to the panelists from members of the audience for about another 15 to 20 minutes. Now I'd like to introduce to you our 4 panelists. Our first panelist is Patricia Gless. She obtained a Bachelor of Science and Master of Science in Nursing degrees from Kent State University. In fact, she graduated in the first class of nurses at Kent State in 1971 and was a junior nursing student on May 4th, 1970. She has worked in many different healthcare settings over the years and is certified as a psychiatric nurse. Mrs. Gless worked at the local hospital as a nurse technician on and around May 4th, 1970, and provided care to hospitalized students who sustained gunshot wounds that day. She is here to talk about her experiences nearly 50 years ago and will serve as a really important anchor to our panel discussion related to advances in the field since May 4th, 1970. Our next panelist is Dr. Claudia Cihlar. She is an advanced practice psychiatric clinical nurse specialist with a doctorate in mental health counseling. She is a 2-time proud alumnus of Kent State University College of Nursing. Dr. Cihlar coordinates the intensive outpatient treatment programs at the Center for Behavioral Medicine. She led the development of the clinical program for dialectical behavioral therapy at Akron General Medical Center with a focus on trauma-informed care. She studied emotion regulation and dialectical behavioral therapy skills with complex trauma patients enrolled in a 12-week program at the center that she works. Previously, Dr. Cihlar worked for Veterans Administration Centers in Kansas City and Cleveland, where she helped establish the National Center for Stress Recovery in 1983 for combat-related PTSD. She developed and led the critical incident debriefing teams for responding to acute trauma events at both the VA and Akron General. Next is Dr. Ostrowski-Delahanty. He is a professor of psychological sciences and associate vice president of research and faculty development at Kent State. His research focused on examining biological predictors of post-traumatic distress in adult and child victims and the development of efficacious early interventions to reduce the development of PTSD. He has authored or co-authored more than 100 publications in these areas, and his research has been supported by grants from the National Institute of Mental Health and the National Institute for Occupational Safety and Health. And lastly is Dr. Sarah Ostrowski-Delahanty. She is a child clinical psychologist and is the Director of Research for the Neurodevelopmental Science Center at Akron Children's Hospital. She is an expert in the area of child PTSD and the impact of family responses on a child's recovery following traumatic injury. She's worked collaboratively with Dr. Ostrowski-Delahanty, her husband, for over 15 years. Her research has identified numerous psychobiological predictors and correlates of post-traumatic distress, with emphasis on how symptoms of family members impact one another's recovery. She helped to establish the Center of Treatment and Study of Adverse Childhood Events and worked collaboratively with Children's Hospital of Philadelphia to examine the use of a toolkit to help reduce post-traumatic stress response in children and caregivers following a child's head injury. Currently, she is examining the impact of emotional regulation on the development of post-traumatic stress symptoms following pediatric injury. Another area of expertise is secondary traumatization, and Dr. Ostrowski has worked with Akron Children's Hospital and the National Child Traumatic Stress Network on raising awareness of the impact of traumatic stress on caregivers and professionals who work closely with trauma victims. Please welcome our panelists. Okay. Hello. Okay. So I'd like to begin our discussion. Can you hear me? Okay. I'd like to begin our discussion of traumatic stress and post-traumatic stress disorder with a first-hand account from Patricia Gless, who was, as I said, a nursing student at Kent State University in the spring of 1970 and cared for some of the hospitalized students who sustained gunshot wounds on May 4th. So, Pat, I guess I just am going to ask you, what would you like to say about your experiences as a Kent State nursing student during that time surrounding the unrest on campus and the shootings on May 4th?
Okay. I would just like to share my experience on that particular day. May 4th, 1970, I was a junior nursing student who was also a commuter student. So I lived about 4 miles away from campus, next to the old Robbins Memorial Hospital, where I worked as a nurse tech on the weekends. I worked there on the weekend of May 2nd and 3rd and was not on campus to witness the events leading up to May 4th. I did keep informed of the events through the news, such as the burying of the Constitution, the burning of the ROTC building, and so forth. So I was anxious to get back to campus on Monday morning to see what things were like. So as I returned, I found Army Jeeps on campus. The National Guard was present as I expected. Classes were held as usual, though, and I went to my morning class where a faculty member came in and made an announcement to us that if any of us could leave campus, we should do so because something really bad was probably going to happen, he said. So I went home, went back home. I listened to the news, and I heard and learned that some of the guardsmen as well as students had been killed. We didn't know this was false information at the time. However, I looked out the back window of our home, which faced the emergency room parking lot, and saw that it was packed with bystanders in the afternoon and cars. I then knew that the injured were being brought in. There were no trauma centers back then. If you were injured, you were brought to the nearest hospital. And so I got a call then to come into work. Most employees that were off that day on May 4th were called into work to prepare for the worst, not really knowing what was to come that day. My mother was also a nurse who was on duty that day at the hospital. I was assigned as a nurse tech to work in the ICU, where I helped take care of some of the wounded students. I took vital signs, I helped get supplies, I assisted in helping get some of the wounded ready for surgery. I was glad to have a purpose on this day. I know my mind was racing, thinking of how many students died, who was injured, were any of my friends injured. Really thinking all this but not knowing any specifics. I tried to remain focused on providing physical care to the wounded. There wasn't time to process feelings. That came later. It was like being suspended in time. My mind could absorb the sights and sounds of the day, but not process any feelings. May 4th was really much more than the events of that day. It was a complicated time. Much later, I thought about this, thought about the students, the National Guard, the soldiers in Vietnam, that they were all mostly around the same age. Some of the students on that day in May at Kent State had already served in Vietnam and were attending campus, or were attending college on the GI Bill to further their education. Some of the National Guard were students as well, and some had been students. I went to high school with some of the guardsmen. On May 4th, 1970, my 19-year-old brother, who is with us here tonight, was in South Vietnam serving as an infantry medic in a mechanized unit less than 2 miles from the DMZ. He was on my mind that day too. I also had cousins, former classmates that were serving in Vietnam. And actually during our psychiatric rotation, we were at the Cleveland VA hospital for that. I was surprised to see that one of my high school classmates was a patient there. He had been admitted for a stress-related diagnosis related to being in Vietnam. For me, there's so much interconnectedness related to this day and all the days that have followed. The number of people exposed to the violence that day, either directly or indirectly, is far-reaching. Some carry wounds that will never be seen. Thank you.
Thanks, Pat.
Thank you.
Okay. I'd like to sort of fast forward now from the wonderful detailed description that Pat gave about her experiences around that time to the present, and ask one of the best experts on trauma, Doug Delahanty, if you could summarize our most current understanding about what PTSD is. For instance, what are the symptoms? Why do some persons who are exposed to trauma and stress develop PTSD while others do not? And which group of adults are most at risk?
I was told I'd go last. No, I also, and I apologize ahead of time, as a faculty member, I could probably do 2 or 3 hours on that. So if you want, just signal and he'll cut off my mic and it'll just stop. PTSD is a disorder that consists of symptoms that one might have after a traumatic event, as already mentioned, types of traumas. It's characterized by symptoms of intrusions, thoughts pop in your head unbidden, avoidance, hyperarousal, and now they've kind of divided up into different symptoms, but basically depressed mood and cognitions are considered part also. I think one of the big challenges to the literature in general, or to society, or just understanding PTSD, is that in general, trauma is very common. 80% of adults have experienced a traumatic event at some point in their lifetimes. But as you heard earlier, the rates of PTSD are relatively low. So it's a disorder that strikes a significant minority of individuals, almost independent of type of trauma experienced. And so what is it that distinguishes those individuals who develop persistent symptoms that are oftentimes comorbid with depression and anxiety and substance and alcohol use and a slew of other negative things from individuals who have a bad experience, but it's just kind of kept at that level of that was a bad experience. And that's one of the things that we find is a huge challenge in trying to identify individuals early on who are more likely to develop debilitating symptoms, and how do we distinguish between those two groups? I'm trying to remember what the third question was, but I can just ramble for a minute and I'll get to it.
Well, you're talking. I mean, what has the research said? The most up-to-date research say. I mean, what are some of the factors that contribute to a person who is at risk? An adult. Let's stick to adults.
Let's do adults.
Adults who are at risk to develop the order versus someone who can experience the exact same kind of stress and doesn't develop the disorder.
In general, what we look at is we try to identify individuals very early on. So I've been very fortunate to collaborate with people at all of the local hospitals nearby, recruiting adults and children within an hour or so of traumatic events. So we typically work with emergency departments and trauma units, and so we'll recruit individuals who have had any kind of trauma, the interpersonal ones, motor vehicle accidents, serious falls, things where life-saving measures had to happen. And the challenge to looking at risk factors is simply that initially, soon after a traumatic event, most self-report indices, everybody's upset, everybody's distressed, everybody's a little bit worried about what happened, and everybody is having pretty high levels of symptoms. So the trick is, how do you identify those individuals who are going to stay elevated versus those that drop off? If we ask people questions, there's no way to distinguish between those two things. So we focus much more on biological mechanisms, and we look at stress responses. And what we found pretty consistently is that individuals who are likely to develop post-traumatic stress symptoms have an exaggerated initial reaction to the trauma. This initial reaction is very high levels of sympathetic stress hormones, as well as HPA axis, or hydrothalamic pituitary adrenal, which is cortisol. So high levels of cortisol and high levels of sympathetic hormones right after an event seem to be related with greater risk of PTSD symptoms 6 weeks, 6 months later. And so that's where we tend to focus more on some of the biological mechanisms. You said focus on adults, but I think one of the things that's most critical to note is when we first found that out, that was probably 15 years ago. We figured we've solved everything. It's cortisol is the big deal. All we got to do is adjust levels of cortisol. We'll prevent PTSD on anybody that we could talk to relatively soon after trauma. And then we ran the same study in kids, and we found the exact opposite results. Higher levels of cortisol were associated with PTSD in kids, whereas lower levels associated with adults. And then we looked at boys and girls differently, and we found they're different. And adults, males and females, are different. And so I think the one thing to get back to in a little bit perhaps is that there is no one-size-fits-all PTSD, and there's no one-size-fits-all kind of therapy to fix PTSD, if you will. And looking much more at the different symptoms that one experiences is probably critical in both identifying risk and identifying therapeutic approaches.
Thanks, Doug. That's why I put you first. Great answer. So let's talk a little bit now about children and adolescents. Sarah, you've had a rich experience, or you have rich experience working with children. Is PTSD manifested differently in children and adolescents compared to adults? If so, how? And which children are most at risk?
You did a really nice job talking about the history of PTSD and the controversies surrounding it. And unfortunately, the idea of PTSD in kids came later. It was kind of initially thought that kids are just little adults and they're going to have these same experiences, these intrusive thoughts, dissociation. That would be very challenging for a young child to understand and be able to express. And so thankfully, the DSM has done a very nice job of modifying the symptoms to be more developmentally appropriate. So for younger children, for instance, under the age of 5, they don't have the ability. Some of them may not even be verbal. Some of them may not understand what's happening to them. They may not have control over their environment. And so we tend to look for more changes in behavior. These kids may start regressing, so they might be bedwetting for those children who earlier had been potty trained. Play is a big thing. You may see them reenacting play or repetitive play. Changes in attachment will occur. These symptoms then change as the child starts developing and growing older. So as the child grows older, you get an adolescent. And so adolescents, there's that baseline acting out that adolescents do, but this is above and beyond, right? So it's that truancy, it's defiance, it is, risky sexual behaviors and substance abuse. And so really it's looking at the behaviors and noticing the change in that.
As a follow-up question, I know that you've done some research on the role of the family in this illness. what role, if any, does the family play in a child's development of PTSD or perpetuation of PTSD symptoms?
I love this topic. So like Doug, I could go for days on this topic. So obviously children don't live in a bubble, right? They are part of a system. And so when we started looking at, we took the study from adults, so from the adult hospitals, applied it to children. We focused solely on the child. And it didn't make sense, right? Biologically, things were wonky, but also the child was a reflection of what's happening in the system itself. And so we started looking at the impact of the child and in the parent. Primary caregivers tend to report signs of distress. Makes sense. Your child has had a traumatic event happen that is upsetting not only to your child, but to you. What we found is that parents actually report higher levels, and that one of the greatest predictors of a child's later distress and just difficulty coping with the trauma is the parent's own distress. And it's been really, really interesting to kind of tease that apart. And when we look at, one thing I always say at Children's is, we do a fantastic job assessing the kids, but we need to assess the parents. The parents are crucial for this child and his or her recovery. A lot of the evidence-based interventions for children that are trauma-focused do incorporate, thankfully, the parents when appropriate. And so that's key. I think it's really just looking at the system.
Okay, thank you. Okay, well, I'm going to move on to talk a little bit more about veterans and other vulnerable populations. Some research findings show that as much as 30% of veterans experience PTSD sometime in their life. Claudia and I go way back, and I remember back in the late 1980s, I was a brand new master's degree prepared psych clinical nurse specialist, and was also a part-time instructor for the College of Nursing at Kent State. And I had my students at the VA in Brecksville. And I remember Claudia, and I'll never forget Claudia, because she came to talk to our students, and she talked about PTSD in veterans, and I learned so much. So, Claudia, what have been the biggest advances in our understanding of treating PTSD in veteran and non-veteran populations?
Well, I remember that too, Wendy. Well, the advances have been huge. I mean, in our understanding, I think you both spoke to this idea that there is physiological arousal as well as psychological, emotional, interpersonal dysregulation with PTSD. And so when we think about treatment, it's important to remember that we have to look at targeting the symptoms and matching that person with the best treatment for them. There are a number of evidence-based treatment models for post-traumatic stress disorder. When I first started at the VA back in the 80s, we were kind of flying by the seat of our pants, because really and truly in the early 80s, the DSM, as you mentioned, Wendy, had really just introduced this nomenclature. And so we were beginning to look at the cognitive-based therapies. And if you look at what our best practices today, the best practices, first of all, are psychotherapy for post-traumatic stress disorder. And when those are combined with biological treatments, if appropriate, the two together will provide the greatest outcome for people with PTSD. Trauma is in the eye of the person who experiences it. And I think that point has been raised some, that there are some individuals whose ability to bounce up from trauma may be higher than other people's ability. But some of the treatments that we're administering now fall into the range of cognitive behavioral therapy, or CBT. There are a couple of them that I'd like to share with you. One is cognitive processing therapy, and essentially this can be done in either an individual sessions or in group therapies. I believe one of our community partners, Summa St. Thomas, does cognitive processing therapy in groups, and they've had a lot of success with that. And basically what it does is it teaches the individual to reframe their negative thoughts. What happens after the experience of trauma, people's assumptions about their safety, the world as meaningful and their ability to control things is shattered. And this was a theory and model of attribution theory that was developed in the late 70s by Ronnie Janoff Bowman. And in practice, what happens to people after they experience trauma is that they begin to say, I can't trust anybody. When in truth, we know that there is a piece of that is a cognitive distortion. So cognitive processing therapy helps individuals look at that. And they do that by challenging their thoughts. So we're using a lot of CBT therapy with that. The other piece to that is that if it's done individually, they will talk through their trauma with their therapist. In groups, that might be a little bit more difficult because you could have the effect of flooding on other group members. It can be very difficult for other people to hear that. And so there are some risks associated with doing that in a group context. Another type of evidence-based therapy is called prolonged exposure. And prolonged exposure is also a type of CBT therapy. It's typically done with an individual therapist over 8 to 15 sessions, about an hour and a half, for about 3 months. And essentially, in this type of therapy, the individual and the therapist create a hierarchy of things that the individual has been avoiding. So as we spoke of earlier, one of the core symptoms of PTSD is avoidance. And so the therapist and the client put together this structure of things that they've been avoiding, like I can't go to the grocery store, I can't be in a room with other people, I can't watch a movie that has violence in it. And so what the person does with the therapist is they do some imaginal exposure in their mind while they're practicing mindfulness techniques, breathing techniques, grounding techniques, until their anxiety level essentially comes down and they're able to approach those behaviors over time. This is a very powerful therapy. Prolonged exposure is also done with individuals who don't have PTSD but may have clinical syndromes like obsessive compulsive disorder and that kind of thing. And then another approach that is actually pretty popular is EMDR, which stands for eye movement desensitization and reprocessing. And there are any number of therapists in our area who do this. And basically, EMDR is done with individuals, with an individual therapist, again, over about a 3-month period for about an hour and a half each session. And this is a really interesting and novel approach because the client does not talk about their trauma, but what they do is they recall their trauma and they hold that trauma memory in their attention while, it's kind of like a dialectic, while they're holding it, the therapist begins to introduce a tone or something visual like a finger going back and forth, a sound, some type of eye movement that the person is focusing on. As they're holding the memory, they're practicing breathing in a mindful way, and over time, they're holding both things at attention until the arousal associated with the memory goes down. It's very novel, very interesting, and actually very powerful. And then the second part of that is that they again do that, but they take that memory and reframe it, and they hold that memory in attention while the therapist is introducing this sound, this visual, and they hold those two ideas at the same time. You know, I'm not an EMDR therapist, but I have colleagues who are, and we have several patients in our treatment program who have found great success with EMDR, so kind of interesting. There are some other novel approaches that I just want to mention. There are apps, you know, we live in the age of apps, right? Mm-hmm. And so there's an app for that. There is the PTSD coach, there's the PTSD family coach, there is an app called Vet Change, which helps veterans specifically to support their efforts to stop using substance. As we know, people will use substance to numb. their painful memories. And it creates its own set of issues, especially when we're trying to help them build a quality of life and get them functioning again. There's also one for anger management, which is specific for veterans. And we know that there is severe sleep disruption with PTSD, which I'm going to talk about in a minute if I have enough time. And there is a CBT insomnia coach app for that as well. The Cleveland Clinic, where I work, also has CBT eye therapy programs for people that have extreme nightmares. There's been some research, and I'm imagining that you guys are probably familiar with this, that immediately following a trauma, if a person watches a visually demanding video game, such as like Tetris, shortly after exposure to the trauma, there's some thought that that may interfere with the consolidation of trauma memories. So we really do need to look at some novel approaches, I think, with PTSD. Treatment is readily available. I think that's important to keep in mind. As far as medications, as a prescriber, I just want to share some ideas with you about this. First and foremost, there are a large number of medications, but just like therapy, we want to individualize it to the person. There are only 2 FDA-approved antidepressants for PTSD. One of them is sertraline, commonly known as Zoloft, and the other is paroxetine, which is commonly known as Paxil. Both of them help in that they tamp down some of the anxiety and the depression that goes with PTSD. But there are also some other novel approaches. There are several common blood pressure medications. I'd like to mention clonidine, propranolol, and prazosin. In particular, prazosin is a medication that I will offer our patients with extreme nightmares. It is very effective at mitigating nightmares, and in particular, if an individual is having daymares, where they're having hyperarousal during the day, we can give that to them also during the day, and it seems to have a significant effect on reducing their distress. So that's interesting. There's been some research. There was a meta-analysis actually done with a study population of over 400 people, where they combined a common antipsychotic, risperidone, in very low levels with antidepressants. And what they found was that there was significant improvement in overall key symptoms of PTSD. So we've come a long way, for sure.
Well, we sure have. And with listening to all that, Pat, I guess I'm going to ask you to share with us what kind of approaches, if any, did you experience as far as by the university or by the healthcare system or by the community at the time back in May 4th, 1970, to help those who experienced the stress of that whole era?
Not anything to speak of, actually. PTSD hadn't been used until, I think, 1980.
Right.
So that was 10 years in coming. Wasn't really recognized. And aftercare for really wasn't a standard of care back then. It hadn't been, I don't think, introduced. I know as a student, I came back to school first summer session of 1970, and that's right when the university opened back up. After May 4th, 1970, it closed down that day and didn't open back up until the first summer session started. And I took 2 classes that session, and then I took another class the second summer session, and we really didn't talk about May 4th, and it was so soon after. It was, I don't know, it was strange to think about that now. But back then, it seemed like we're having business as usual to get our classes done, but yet That was on all of our minds, I know. It's not a criticism at all.
No,
It
it's
was the
just
time.
way
It was the
then.
time that we were in, 1970.
Right.
But I'm so glad that that care is available today.
Yeah. Doug, you've done some research on identifying individuals who are at risk for developing PTSD and intervening early. Could you describe some of those interventions?
I think most early interventions are experimental at this time. So I think one of the main challenges to the literature is, again, if only a minority of individuals develop symptoms, how do you identify those individuals? And then how do you target them appropriately with treatment? And one of the challenges has become that initially it was thought, well, what you got to do is immediately now, when they're moving into more recent times where there's a better understanding of the consequences of trauma, get them to talk about it right away. Put them into rooms, get everybody into a room who's experienced this and talk about it right now. And unfortunately, those approaches have typically been found to be very mixed. Oftentimes they will, there's enough studies that have suggested that you can actually make people who are going to be fine worse by forcing them to talk about it and experience it at a time when they just don't want to. They don't have the resources to deal with it. And so it doesn't make sense to take people, and that's what critical incident stress debriefing approaches have been cautioned in the US and Canada, because you don't want to take people in the immediate aftermath of a trauma and make them do something they might not want to. There's much better evidence for waiting. And so you have diagnoses like acute stress disorder. If you wait a couple weeks, then you intervene with individuals who are still symptomatic. A phasic approach seems to be the best. What we try to do research-wise is see whether or not we can back up that clock. If psychotherapy is not a real great idea within hours or days of an event, are there medications that can be looked at? So propranolol is one that we've used in child studies and shown some efficacy at preventing PTSD in boys. Again, I talked about there's gender differences that we find in things. We've done trials with hydrocortisone in adults and shown some efficacy for clinically significant decreases in symptoms later on. There are randomized trials right now of a slew of different medications. Lots of different things that people are using to self-medicate already. There's marijuana studies that are being conducted right now. There's a variety of different illicit medications that are being looked at for their possibilities as early interventions. All of those are mainly experimental at this point. But the current best practice, if you will, from soon after an event is you probably don't want to do anything immediately. Hypothetically, if you can phasically approach and say, this half are going to be fine. Then you focus on the other half. You test them again a couple weeks out. Individuals who are heavily symptomatic at that point are offered some type of an intervention, and that has been shown to be efficacious. Some of the interventions that you mentioned, you can do them in a truncated fashion. 4 sessions of prolonged exposure or CBT have been shown to be beneficial at that point before you can even diagnose PTSD, because you have to have the symptoms for at least a month to be able to receive a diagnosis of PTSD. So you do have some preventive capabilities, things that you can do early on, and then things that you can do once the 1 month time point has passed. It's that phase that you want to really try to, that's where we're focused on, because most research shows that if you can address it at that point, you'll be okay. If people are symptomatic at 6 months, it becomes much, much more challenging at that point.
Well, I'm looking at the time. I want to ask a couple more questions that I really want to get to, because we haven't talked much about it. And one is this whole construct of secondary traumatization. And it seems that in my reading prior to coming here today about PTSD, it's popping up quite often in the literature today. And Sarah, I know that you've studied this. So could you tell us what secondary traumatization means?
No, you're exactly right. It's kind of the buzzword right now in all sorts of professions. So listening to people who have had a trauma can be tiresome. It can be overwhelming. It can be to a point, as a professional, you start to question your own life. You start to question things that are going on within you, and that is very challenging. A lot of words are now being thrown around. One is compassion fatigue. So it is what it sounds like. You are fatigued. You are emotionally drained. You are tapped out, and unable to be there for your patient or client or whoever it is that you're working with. Secondary traumatic stress is more specific to PTSD. And I was thinking about the story that you had shared where you weren't there on May 4th, but walking.
Right.
And you started to, you felt it in you, even though you weren't even there, you could feel that. And that's a good example of secondary traumatic stress. You're almost having those visuals, start avoiding things. Personally, you know, we have a young daughter, and seeing all of the ATV accidents and everything else has put me just avoiding, we won't do them, to a point where my husband makes fun of me a little bit. But it's what I've experienced. And it's been really interesting what the research has shown. With respect to nurses, so it started in mental health. You know, the people who were working in the VAs were really getting burnt out. They're turning over, they're leaving their jobs, they're making medical errors. It started to span into other professions. Healthcare is one of them, which is really, really nice to see. In nurses, it's been fascinating where you look at nurses who report symptoms, and over 80% will report at least one symptom of compassion fatigue. 30% will endorse all of them. And this is incredibly problematic. I mean, not only for them as an individual, they're at risk for mental health disorders, substance abuse, and isolating themselves, but also for the patients, so the medical errors that can happen, and then organizations, so the turnover and not showing up to work. In healthcare, some of the common risk factors are, one, being a woman, being overly empathetic, and working in high stress departments, right? So the EDs, emergency departments, the ICUs, the people who deal with trauma victims are really at risk, as well as in one of the common themes that they're finding, it's nurses, and we run into this in our PICU, which is interesting. The nurses don't feel trained. They don't feel trained to do their job. They feel that they're thrown into this very stressful situation, and they don't know what they're doing. Not even psychologically, but just they feel very overwhelmed, and they're more at risk for experiencing this compassion fatigue and just leaving the department quickly.
And just one last question before we open it up to the audience. What do you predict will happen in the future, near future, or a few years out? What are some new avenues that show promise as far as treating PTSD? And that's for anybody who wants to answer.
I can go real quick.
Okay.
I think in the future, what we see right now from a funding agency standpoint, even NIH, who funds lots and lots of our research, is less and less of a focus on PTSD specifically. And I think, as we've been talking, we talk about PTSD, but PTSD is extraordinarily rare on its own. If you can find a person who has pure PTSD with no comorbid disorder at all, it is very, very, very rare to find. Depression is more common than not in PTSD. Anxiety is more common than not. Substance and alcohol use is more common. It's about 50-50. And so you have a disorder that has lots and lots of other components on it. And one of the things that's interesting about PTSD is we talked about the symptoms. To diagnose it, you have to have one of these and three of these and two of these and one of these. And if you have just that, you can have PTSD. Mathematically, there's been articles published. You can show there are 676,000 patterns of symptoms that can cause PTSD. So I can have, actually every single one of us up here can have PTSD and not share a single symptom. And so if you think about it that way, why would we treat each and every one of us in the exact same way if we don't even have the same overlapping symptom? We have clusters, we have similarities, but we don't even have the same exact ones. And so I think understanding more the breadth without a specific focus on just the diagnosis, not saying everybody with PTSD is the same and we should treat them all the same. I think that's really where we are right now, is understanding whether there are consistent subcategories, whether it should be more symptom focused as opposed to whether or not, the other thing would be obviously if you miss just one of those things, you don't have PTSD. But if you miss just one of those things, you have as many difficulties as somebody that doesn't has all of them. So more of a consideration of a continuum, if you will.
Okay.
I told you quick and I lied.
No, that's
Sorry.
great. Great. Thank you. Okay, we're going to open it up to the audience now, and we have a microphone here. Hopefully it's on and ready to work. So does anyone have a question that they'd like to ask our panel? You can come up here Or should I come with it? Maybe I should come and,
Someone mentioned that pressuring people to deal with PTSD right after the event can sometimes have an opposite effect. So why, in my mind, for example, in Parkland, the next day there's all these psychologists and people coming to the schools? Is this putting too much pressure on the children at this time to cope with something without giving them, as you mentioned, a week or two to focus on it?
You want to do it, or? So I think the provision of aid or listening to those who would like some is a fantastic first approach. The issue with critical incident stress debriefing is after a school shooting, take all the students into a room and talk to them, and then make them talk back about their feelings. Does not work well. There's been studies in burn victims, so if you take and you do the same exact thing, if firefighters, EMS workers, after a specific event, making people all cope in a similar way. People are very different. Some need time. Some can't process it right now, and I do not want to be talking about it. I don't want to be talking about it in a large group of people. So the school ones, providing those resources. Now, there's plenty of people that will take advantage of that and benefit from it, but it has to be what they're looking for, not that somebody comes in and says, I will be helping you right now.
So there really isn't any coercion involved? Or, I mean, for example, do people feel like, the students feel like they have to participate in this to be like their classmates, peer pressure and stuff?
I think that's the message that you send out. I mean, so that's just dependent on how the communication comes across. And I think that's contingent upon the individuals offering that support. The idea would be people cope with things differently. You can have the same conversation just around death in general. People cope with the death of a loved one in different ways. So how do you think that we could be helpful to you? Do you want to go and sit and talk with friends and talk about this event? Do you want to be on your own for a little bit? We'll be around here. We'll be around here for a couple weeks. So if at a later time you're feeling like you would like to have a conversation, we'll be here for you is really the message you want to give off. I think the, hey, you need to do this now because we know what's best for you is really wrong. And I'm not so sure kids are really, I don't see that as that much of a potential coercion if you give the message in the correct way.
And may I have another question?
Sure.
While I'm here. For the woman who was a student in 1970, I belong to a Facebook page for the Visitor Center, and every now and then they have a notice about a PTSD for May 4th survivors. Are you aware of that, and does anybody know anything more about it?
Yes, I'm aware. I haven't attended yet, but I'm glad it's there, but I really haven't investigated it.
Okay. So maybe somebody.
Mm-hmm. Thinking about it. Thank you.
who else has a question?
Can I be heard from here?
Sure, maybe I can take the
If you want, I can just
microphone
restate it so people can hear it.
Here you go.
Two questions. Thanks. The first is, are there varying degrees of PTSD? Are there people that barely show anything as opposed to people that are abusing drugs and alcohol and things like that? And the second was sort of close to what the gentleman just said. Is there any data on May 4th survivors, people who witnessed about PTSD levels in survivors, about this specific incident?
I have no idea.
Sarah's hard of hearing, so she's saying, I have no idea what anybody said. So what do
sorry.
you guys want to answer? Or?
I could address the one just a little bit about the studies for PTSD. I'm aware that there were some studies early on, like maybe 1973, by Raymond Adamek and Jerry Lewis, who were both professors here. They did some studies. I haven't seen them, but I've heard about them. And they, of course, PTSD wasn't really defined back then, but they were looking at stress levels of students who were here at that time. So, but I don't know of anything current. But since I've heard about this study that was done, I think it was done over a period of a couple of years, I really want to find the source and read about that, because I think a couple of the results that these two professors found was that the students that had been here on May 4th that they studied became more political and less tendency toward any violence at all. So anyway, I do want to read that. I think that would be good, but I don't know of anything current.
I think we have one more time for one more question.
Thank you. I was a student here in May of 1970, and so many of the people I knew then are still very emotional about that day's events and very stressed by it. Some even say that they have PTSD and maybe they've been diagnosed, I don't know. But I'm wondering, after 50 years, what can someone who experienced those days' events do to help themselves if they still feel that they are suffering the effects of that day?
I think I can maybe help address some of that. My experience as a clinician in this field for many years, oftentimes adults will come to us who had childhood trauma. So we're also talking about a span of maybe 20, 30 years. And either they've held it close to their vest and they haven't talked about it, and perhaps later in life there's some type of event that triggers a greater amount of distress. I think the hopeful news is that at any time in a person's life, they can, if they feel that they want to begin to look at it, they can benefit. I do believe that it's connecting the individual needs of the person who's suffering with the best treatment and the best clinician for them. So there are so many individual differences, and fit is such an important component of effective therapy. You can do the correct therapy, but if the therapeutic alliance, if the connection between the therapist and the individual seeking services is not there and it's not a good fit, we don't want people to leave feeling demoralized, that after all this time they've finally found the courage, if you will, to come and talk about what's going on with them, and then to find that it's not a good fit and to feel like they should give up. So I think it's really important as therapists to give people hope. That's part of what, we didn't talk about it tonight, but that's part of what trauma-informed care is all about. It's really creating an environment of caring and compassion, but also an awareness that this is a very painful step for people to come forward, whether it's 2 years later, 15 years later. I can tell you that just very recently in my work that I have a client that I've been working with for probably 25 years, an older adult in their 70s. And in our last session, and I've known this person, I've seen this person for so many years consistently, and we have a very good relationship. This person shared with me a trauma that had occurred in their 20s that this person suffers with every day. And this person had never shared this. And so we're now on a different journey together. So there's hope for that. And I would encourage anyone who's feeling that alone, because trauma leaves a sense of aloneness, that people feel disconnected from the rest of the world. They feel as though they can't relate. So I would encourage anyone who's struggling with that to come forward and take that step to find somebody.
I think significant commemoration helps.
Yes.
And I think you've seen that with May 4th in Kent State.
Yes.
Whenever we, as survivors, felt that it was brushed commemoration wasn't given, the appropriate time, that classes weren't canceled, whatever. I really think that coming together is a very important way of dealing, not with PTSD necessarily, but with our sadness, with the way our lives changed that day. I think that's really helped over the years. And now that May 4th has a center and all these people working on the commemoration, I think that's been really a good thing for us, or for survivors.
Yes.
Okay, I guess our time is up. I would really like to thank these 4 panelists. I think they were wonderful. I learned so much from each one of you. Can we give them a big round of applause? Thank you also for coming and for asking such great questions and participating. We do have some refreshments for everyone out in the lobby, so please join us out there and to have some refreshments and talk a little bit more. Thank you.